Good evening, everybody. My name is Bill McGarvey here on behalf of Our Lady of Mount Carmel in Tenafly, New Jersey. We're very happy to have you with us here tonight on Facebook Live, and really excited that we have members of our community and our extended community from the medical community who have been willing to sit down with us and talk to us, because there's a lot of questions out there about COVID, vaccines, vaccine access, who should be getting it, who shouldn't be getting it, et cetera, et cetera. There's also a lot of misinformation out there, so we thought we would ask a few of them to sit down with us to talk. And we'd love you at home, if you have any, or wherever you are with your Facebook. If you want to type in any questions, we'd be thrilled to ask the doctors here, but we also will keep a conversation going here. I'm going to introduce you now to Dr. Dan Triolo, who is a member of our community here, and she's going to introduce herself and her medical colleagues as well. So there you go.
Hi, so I'm Diane. I'm a parishioner here at Our Lady of Mount Carmel, and two of my three girls go to school here. My youngest is only 2, so in a couple of years. And I'm a nephrologist in the community, and I'm very excited to meet my colleagues. So this is Dr. Suraj Sagar from Infectious Disease at Holy Name Hospital.
So pleasure to be here. Thank you, Diane, for asking me to come. I want to applaud you all for attending this evening. It shows a lot of initiative to, obviously separate fact from fiction, and we hope we can do that this evening. But it's my pleasure to be here, and thanks for having me. And
then Dr. Clinton Coleman, who I'm sure many of you have known from the parish. His kids used to come to school here. He's also my partner and a local nephrologist.
Glad to be back. Thanks for having us.
Great. So just on a real broad level here, we're just going to talk for a few minutes if we can. We've been through a lot in the past 15 or 16 months in the United States. Where are we here in Bergen County or northern New Jersey in terms of the virus? It's kind of an open question. Can you tell us where we are in terms of, people getting it, people getting sick from it, people dying, vaccine level? Can you give us a little lay of the land right now, any of it?
Yeah, sure. So, Bergen County, in particular, Holy Name Medical Center in Teaneck was the epicenter of the pandemic. Certainly in 2020, we've had several stages or waves of COVID-19. So we've had a lot of experience, but that was a trial by fire, if you will. And if we look at where we are now compared to back in March of 2020, we are actually our lowest, we called positivity rate since that time. We only have 3 patients in the hospital currently, where at one time we had over 250 patients, and at one time we only had COVID patients. So we went from very quickly from our first patient, my first patient in March of 2020, to the entire hospital being occupied by COVID-19 patients, to now only 3. So it's a dramatic and impressive final decline in cases. We were very relieved. It's a reflection of vaccination rates that are very high, thankfully, in our community. That's not the case in all parts of the United States. It's certainly not the case globally. So it's certainly a race between the vaccine and vaccination and the virus replicating and finding a host. Luckily, currently, as of right now, we are in a very safe and good spot.
Great. Dr. Triolo or Dr. Coleman, any addition, anything you're seeing in your practice?
I would hope to say that we've turned the corner. In our experience in the hospital, it was like a war zone with, nonstop. We were there 24/7 almost, dealing with these patients. But I think, social hygiene, wearing masks, and using the vaccine have decreased that amount. So, unfortunately, that's not the rest of the country. But thankfully, we've seen the cases decrease in our area.
What does that mean? Do we think, is it because the vaccines are out there? Can you give us a sense of this? I read a lot about what's going on in India, sadly.
Sure.
So there's a lot of questions we can get to about variants, et cetera.
Absolutely, sure.
But let's talk, if we can, about what is causing the steep decline that we're seeing right now, and how can we keep it going in that direction?
Yes, I can take that. It's a multitude of factors. If you may remember, last year we saw not such a steep decline also this time, and that has to do with environmental factors. So the temperature is warmer, people are outside, the weather gets more humid. Humidity is less advantageous for the virus to go from person to person, so you have those environmental factors. But of course, the major issue we have now is vaccination rates. The vaccination rates in our area are now over 50% for adults. Of course, we're going to get to children and adolescents in a minute or later on in the broadcast, but essentially the vaccine is extremely effective at preventing infection and preventing people from transmitting to other people. It's not 100%, no vaccine is, and we can talk about what that means. But certainly at this point, the combination of environmental factors, people that have been wearing masks, so of social distancing, like Dr. Coleman alluded to earlier. And also, a significant part of our population had been infected. So we have a certain percentage of people, probably 1/3, that have what we call natural immunity. So you add natural immunity plus all the people now that have immunity we call passive from vaccines. And really the virus is having a hard time finding a host. That may not be, not a static situation. That may change in the fall and winter of 2021, 22. So we have to be aware of that. We can talk what that means. But for now, the virus is essentially having a hard time finding someone to infect. And so we're seeing the rates go down dramatically. We call the positivity rate, so the percentage of people that we're testing. At what time it was 20, 30%. Right now it's 0.83% in the New York tri-state area, so less than 1%. And when you have such low rates, the virus, the number of people keeps dropping and dropping and dropping. So we call that the decay. It's a mathematical equation. When we plug in the numbers, it just points to the numbers continuing to decrease.
And I think we saw that in the hospital in the beginning with a lot of older patients,
Sure.
patients with chronic diseases that were being admitted, and gradually as they got vaccinated, they weren't the ones coming in with COVID. It was then the younger population that was coming in. Unfortunately, as they got vaccinated, that's why we're seeing the numbers that we're seeing today.
Are we seeing, I've heard, and I'm going to speak, I'm the man on the street who's basically hearing things and talking to people. Sure. Are we seeing older folks or people with pre-existing conditions getting COVID and surviving now in ways that they wouldn't have maybe a year ago? Is that partially because of the meds we have available now? Can you talk a little bit about that, what we're seeing, Dr.
I think part of it is testing. We're testing way more and getting more information earlier. I think in the beginning we didn't have access to testing, so we didn't know. People were just staying home feeling sick. Right. But now, the sooner you come to the hospital, the treatments are better. We're starting treatment earlier, and I think patients with high risk like diabetes, obesity, high blood pressure, they're doing a little bit better. So we're seeing that decrease. Okay.
Yeah, and I'll just add that when we first started, we relied on data from China. So we were trying old HIV medications for malaria. We really had very limited experience. Now you fast forward, and what I tell people is that it's better not to get COVID, but if you're going to get COVID, better to get COVID now in 2021. Right. We have monoclonal antibodies, we have antivirals, we know what to use. Without getting into any details, COVID is several stages of the disease. We're much better at the earlier stages. The late stages, unfortunately and sadly, we still have very limited therapeutics we can offer. So certainly prevention is the best therapy here, but at least we're in a much better situation than we were, let's say back in March 2020. We were trying everything in the kitchen sink, oftentimes with very poor success.
People are talking about, I also hear a lot of chatter, of course, about which vaccine do you get? I mean, it's funny how people say, which vaccine do you get? People are asking these questions. Nobody before in their life has ever said, what kind of chickenpox vaccine did you get? You know what I mean? So it's interesting that people are talking about that. What do you say to people that come to you and say, well, I got the Moderna, or I got the Johnson & Johnson, or I actually heard a friend of mine's mother in Colombia got a Chinese, the Sino. Can you talk about that? I mean, you don't want people to start arguing about better vaccines, but can you talk a little bit about what you're seeing and what the efficacy of different vaccines are?
Sure. So, broadly, there's two classes of vaccines. There's the messenger RNA vaccine, that's Pfizer and Moderna, and there's something called adenovirus. And adenovirus is the Oxford, AstraZeneca in Europe, and in India, in the United States, is the Johnson & Johnson or Janssen. And they have subtle differences, but I think for the general public, we should understand that they all are highly efficacious. Yes, they have certain different numbers. Some are 2 shots, some are 1 shot, some require cold storage, some don't. The Pfizer's 3 weeks between each dose, Moderna's 4 weeks. But I think people shouldn't be too caught up in those issues. The supply now far outweighs the demand, so we have plenty of vaccine available. And I think it's more important for people to just understand what is available for their demographic, for their age group, and they should go forth. I think you're absolutely right. A lot of people, it's like saying, where are you going this summer? I'm going to Disney World, I'm going to Disneyland. Did you get Pfizer? That's right. So, and I think the differences are very subtle, and they're important in scientific circles, but for the general public, they're essentially equivocal.
And so the notion is Johnson & Johnson, when that came out a month or so ago, again, from a complete layman standpoint, I read that, I was like, this seems like a tempest in a teapot. This might not be people dying is always, but there was 6 people out of millions, right? My sense is we believe that could have been not coincidental, but can you talk about it? So the fear around that is, of course, everybody immediately points to that as like this is not healthy, we're going to get sick from this.
Yeah, so any vaccine, if you have a side effect, you have to say, is this a causality or is this an association? And with all of the vaccines, they pause them intermittently to say, if there was, like, for instance, Bell's palsy with the Moderna and Pfizer vaccine, that happens anyway. So is that any more, the incident any more increased than what we normally would see? Same thing with the Johnson & Johnson, the AstraZeneca in Europe, where they had these very rare type of clots in the brain, sinus venous thrombosis. These occur anyway. And when you're talking about giving a vaccine to tens and hopefully hundreds of millions of people, you're going to see outliers, and that happens. But understand that bad things, unfortunately, as we talk about, whether it's in church or anywhere, unfortunately happen to good people. So we know the same thing happens in the general population. So we can't always associate a bad thing happening and then someone got a vaccine 2 weeks prior to the vaccine being the cause. I think people have to understand that. People unfortunately get strokes and heart attacks every day, and it just may be coincidence. So that's the scientific process. So when you see these clinical pauses, people should be relieved that that's the scientific process doing its job and doing its due diligence. It's not taking emotion out of the factor and just looking at the science and the data, and then they pause, they do statistical analysis, they say, you know what, there's no more increase of incidence of this adverse effect than there would be in the general population, and then they continue. Of course, that can sometimes cause a so-called crisis in confidence, but that's really the scientific process doing its job.
And I think the interesting thing is you're watching the scientific process in real time, right? Sometimes we have the luxury of just taking a Tylenol and not knowing where it came from and all the rigorous studies. So the same thing with the vaccine. People think this was like made overnight and we're just experimenting. Like this messenger RNA technology has been around for a long time, with 10, 12 years, I guess.
That's right, yeah.
So, literally what I explain to patients is that you're not getting any of the live virus, you're not getting, it's not changing your DNA or anything. You're really getting a message, a post-it note that'll tell your cells to make this spike protein, which is, what's the most virulent part of the vaccine.
The antibody against the spike
So you just develop your own immunity. So I think when we look back at this, this is probably one of the modern marvels of technology, just the vaccine. And you think in context of other vaccines as far as efficacy, meaning how effective it is,
right.
95% is pretty good when we're looking at flu vaccine, 50, 60% per year. So
we really haven't had a vaccine to be this strong and this efficacious. And,
This quickly.
Yeah. Well, and again, people will say, like Dr. Coleman alluded to, that it came so quick, but this is just a culmination of decades of research. Of course, we're not lucky to have this pandemic happen, but we're lucky that it happened in this time where this technology was just waiting for something to kind of attack. And so this technology, which started actually with 2 Turkish scientists in Germany in the early 2000s, has been worked on for several decades.
And I think looking at other vaccines in the past, like the polio vaccine, they weren't able to test it on thousands, millions
Sure.
of people. When it first started, it was like, your child needs a polio vaccine, and people got it. So I think we're lucky that we're able to test it throughout the entire world.
Yeah. What about in the community? This is sort of like what in the communities you serve? So, somebody might say 80-year-old mother, somebody's got a 35-year-old mom of kids versus people from different backgrounds. Can you have a sense of the different communities you serve? What are the questions you're getting or the fears you're getting? And also, how do you answer them? Because I certainly have friends, I have friends from different communities, from minority communities that have said to me, oh boy, I'm not sure about this. So can you talk about that?
Well, Clinton should start.
yeah, I think we see a wide range of people who are healthy saying, I don't need the vaccine, I'm low risk for it.
Right.
But then you have to take into context that they may be around people who are at risk and they can get affected by COVID. But we also see people in communities of color who have had an unfortunate experience or a history with a mistrust of the United States and the scientific community. So they're very hesitant when taking the vaccine or anything that's perpetuated as being new. So, some of that is, a systemic issue, having access to good health care, access to good information. So a lot of it's based on rumors, and you hear stories about the microchip and changing your DNA and all this other stuff. So I think part of that is, we talked about the infodemic and the pandemic. This is trying to get the correct information out there. So we've had a lot of work to do in those particular communities.
Is there anything that works in those instances when you talk? Do you find anything that turns?
Well, sure. And what we tell people is that this is the first pandemic in the social media era, so it's really just checking your sources. Because anyone can post something online and looks very pretty and polished, and they have no medical or scientific credentials to back it up. And so I urge anyone out there, whether they listen to us or listen to anyone, just to understand where this information is coming from, because the infodemic is real. This pandemic and the social media era is very real, and COVID-19 in general to all of us has revealed inequalities and social inequalities and healthcare disparities, and certain communities have been disproportionately affected. Especially the African American, the Latinx community, communities that, like Dr. Coleman mentioned earlier, don't have the same access to healthcare. They may have a mistrust. There may be cultural issues as well. So it's made us realize to be culturally competent physicians, and that we have to do community outreach. We all do it in our way, whether we're talking to patients. Dr. Coleman and I have a podcast we talk about a lot, trying to reach out to the local communities. But it's really establishing that rapport, that patient-doctor relationship, but then also in a bigger audience or circle, doing it to the community. That's why something like this is so important, just to kind of separate fact from fiction and getting the information out there.
And I think hearing that we've gotten vaccinated, our families have gotten vaccinated, it puts patients at ease. Okay, I'm not alone. I think a lot of patients are worried, am I going to get a response to the vaccine? Is it really going to work? And it's just reassuring them that it's been tested. It's stronger than even the flu vaccine at times.
That brings up a question we got on Facebook just now from a woman who asked, what about young women and hormonal issues potentially? Any evidence around this, or anything we can talk about fears around getting the vaccine for that age?
I think the question is fertility, I guess, is what a
Oh,
lot of young
I think it was for young, good, Mr. Eaton.
Young girls, I think, administration.
Young, I heard the rumors that, if you
What's
get the
the rumor?
vaccine and you're menopausal or you're premenopausal, or even before maturity, you're going to start getting your menstrual cycle or those.
Yeah, these are all unfounded.
Yeah.
There was even on social media, this all started because they said that the antibodies that attack the spike protein, which is the target, also attacks the placenta, and they will affect fertility, and women, and younger women will affect their menses. And these are all disproven. And I'll simply point to the American College of Obstetrics and Gynecology. That's the largest and most well-respected medical community for obstetrics and gynecology, and they have unequivocally and emphatically denounced any of those rumors and have advocated for the vaccine for those that may be pregnant, they may be thinking about getting pregnant, those after their pregnancy. There's no effect in breastfeeding, there's no effect in fertility, and there's no evidence to show that it affects adolescents in terms of their sexual development and maturation.
There's
I just
another.
wanna add on to
Sorry,
that,
Dr. Coleman.
No, this process we're all learning. Even the smartest people in the world are learning as we go, unfortunately. So sometimes even we get frustrated with the recommendations from the large organizations, including the CDC. Like one day it's wear a mask, the next day it's not wear a mask, and so a lot of those things are seemingly contradictory sometimes. But what we try to do is encourage our patients to do their own due diligence and get the knowledge themselves or seek medical attention.
Absolutely. There's a question online also from our viewers at home about breakthrough viruses, people that have gotten the vaccine. Is that the
Sure.
Can you talk a little about that? People that I guess have been vaccinated but then get COVID again or something?
I think the Yankees are.
Is that rare? Is that happening?
Yeah, so probably a lot of people heard about the Yankees, but that's a perfect model, is that no vaccine is 100% effective. If you're talking about 95% efficacy rate, when you're talking about tens and hundreds of millions of people vaccinated, then that 5% will still equate to X amount of people. But what we're seeing is those cases are oftentimes mild or asymptomatic. Those 8 Yankee players had no symptoms. They would never have known that they were positive, except it was just MLB, Major League Baseball policy to test every week. And these are people who are living together in close quarters, in close contact. So the vaccine still worked. They had no symptoms. They weren't even had a sniffle or a cold. They were playing baseball. They would have never known they were positive, except that by policy, because right now we're not necessarily going around and testing people who are asymptomatic. And people aren't going every week and getting tested. So people still realize that they are still likely to be asymptomatic. And those baseball players, because they have such what we call low viral load, are very unlikely to pass it on to other people. So that's still a win in anyone's book. So it's not just a matter of someone's positive or negative. We look at something called a viral load, how much virus is in someone's body. The higher the viral load, the more sick they would be, and the higher the viral load, the more likely it can transmit to other people. So the vaccine still worked in this case. It caused the people to have an asymptomatic disease and have a very low viral load and be almost impossible for them to transmit to other people.
Great.
Which works, I'm sorry, I was going to say it works even better than the flu shot.
Yeah, absolutely.
I'm going to say, my dad, actually before COVID, he got the flu shot back in 2020. He gets admitted, Clinton admitted him with the flu. And he actually had to get hospitalized. He's fine now, but that shows you that the patients who are getting COVID after vaccinated, those rare cases, a lot of them aren't even requiring hospitalization or even know it. How stronger that vaccine is in comparison.
Thank you. Diane Hurtado online asked, do we have any sense of how long the efficacy of this vaccine is? Some people say 3 months, 6 months. Do we have any sense of how, anything about the accuracy around that? You know?
Right now, it's going to be most likely within a year, you will need a booster or adjunct. That's twofold. One is to increase the immunity, but actually that may be more likely to address what we call variants. And there's two types of variants that we were worried about, variants of concern and variants of interest. You alluded to earlier to talk about what's happening in the world, but we now...
Variants of concern, I thought variants were like India and South Africa.
Two things. One, now we no longer call it by country because that to remove stigma, etc. And also, we don't know necessarily that's where they came from. It's just that those are countries that have the ability to sequence the variant. So we're realizing now that if a variant first showed up in India, it may have come somewhere else. So that doesn't necessarily know where it came from. So since we don't name hurricanes after Greek letters anymore, we are now naming variants after Greek letters. So the UK variant is now Alpha. The Indian variant is now Delta. In Vietnam, they have a new hybrid, which may be Alpha Delta. We're looking at that right now. But basically, 2-second primer is that viruses are constantly trying to replicate and they're sloppy. And so they make these errors. Oftentimes these errors are nonsensical. They don't mean anything. But if you get a bunch of errors together and they may form a variant. And the variant may mean nothing. It may be the same as the normal virus. It may mean a interest, which means it could cause a problem, or a variant of concern, which is either it's more transmissible, it goes from person to person easier, it causes more disease, it's more resistant to our vaccines, or it's resistant to therapies we already have. And so that's kind of what we, as an ID doc especially, what keeps me up at night is that things are, yes, quickly returning back to normal, but we have to constantly be on our vigilance and our guard for these variants, just like influenza. That's why we get influenza shot every year, so just think of it that way. The good thing about the messenger RNA, and you can, as Dr. Coleman mentioned, you already have these instructions, so we have the hardware, so we just keep updating the software, and most likely we'll be updating the software every year.
But would someone who has Pfizer vaccine last year need to get, or they don't know yet whether they need a Pfizer, the same Pfizer?
Yeah, that's actually a great question.
Or if you had Johnson & Johnson?
That we don't know. Actually, they've done some studies where people have gotten one vaccine and then another vaccine later, and their immune system is even stronger.
I think they're doing that in Canada.
Yeah. So it seems that you can mix and match like baseball cards and throw them around. So that is still to be determined, but I would say as of right now, our best guess the science is still happening as we go on, but as we speak, but it will be a yearly vaccine. And again, people should look at that not as a negative, as a positive. Hey, it works very well, and we can update our software. I mean, we all update our iPhones all the time, so what's the big deal? Go and get a adjunct or a booster once a year.
So these essentially viruses, if you're right, they're always trying to change to get to live, right? They're always trying to find ways to live.
The interesting part about this virus is that, viruses do best when the host stays alive. They get sick enough so they don't die. So we always talk about Ebola virus. It's very lethal. It doesn't spread that much because the host always,
That's why we don't have pandemics of Ebola. It causes people to get too sick.
But something like COVID, which is, we saw this previously with coronavirus and common cold, it spreads like wildfire, and you get sniffles, you get a little sick. Right. This is obviously more lethal, but it gets to a point where it gets you sick enough, and not to kill you, but enough to spread it to someone else. Yeah. So that's why the vaccine is so important. So it prevents you from getting really sick and helps prevent it from spreading.
And the virus won't be trying to find ways to vary itself and then get these variants out there.
It's not trying. It doesn't have a conscience, but it can't. It's a joke, but it can't reproduce by itself. So by definition, a virus has to have a host. Right. It may be an animal. Best we know, this was initially an animal and jumped to human. That's called zoonosis. Of course, we all know that they're still trying to investigate the origins of this virus. But the reality is that it's a sloppy reproducer, and it just makes these errors as it does it. It doesn't do A to B to B to C. There's often just random mutations. And by random chance, it's almost like chaos theory, if anyone out there listens. is in the math. It just, by random chance, you will have these variations that will come together to cause a variant. But like Dr. Coleman mentioned, this is almost the perfect storm. It gets people sick, but not too sick. And the people that are sick can still go out and about and do things and infect other people, as opposed to Ebola. Someone with Ebola dies very quickly, very short incubation period, and they're too sick. They're not going to go to the movies or come to church or go to school. So here, because so many people are asymptomatic but can still transmit, it just reverberates back, reiterates why we need the vaccine.
There's a great question online here from Eric Marks about a news article about heart inflammation and vaccinations in children and young adults a week or so ago. Do you have any further information about that? I'm not aware of that.
Well, we can talk. There's something called myocarditis. That's the inflammation of the lining of the heart. There have been isolated reports of that. Again, very rare, and colleagues can comment more. But I would just say that the chance, we've seen these inflammatory syndromes in children with COVID. So the chance of something happening, both are relatively rare, thank God. But they're still much more common with someone who got COVID and then gets this inflammatory syndrome, this pediatric inflammatory syndrome. So for people to kind of just focus on the 1 in 2 million or 1 in 3 million incidents, and that is kind of like you're losing the big picture here. So it has been reported. People are looking at it. The vast overwhelming majority, again, very rare. The vast overwhelming majority of people recover. Any vaccine, you're going to have these kind of, or any medication for that matter. People will take Zithromax and Tylenol, and too much Tylenol can cause liver failure. So my point is that all medications have the potential to have adverse side effects. It's something that we look for, that we certainly keep in the back of our mind, but not something that is happening on a regular basis by any means.
And I think in some cases they weren't sure if the patient didn't have COVID before the vaccine.
That's right, yeah.
So they're not sure in some cases whether it was actually from the vaccine versus from COVID, the virus itself.
Or even another virus, because many viruses cause myocarditis or viral cardiomyopathy. These are kind of big words out there, but many, and a lot of times we don't know. It's just we'll just say it's a viral syndrome. So that's an excellent point. Kids get viruses all the time, so we don't know if it was the chicken or the egg. Was it just coincidence that someone got the vaccine?
As powerful as social media and as much good as it can do, it also sounds like it really has its own sense of being a virus, where a little bit of bad information or a little bit of information unfortunately gets blown out of proportion, and we no longer listen to the experts and say, put this in perspective. It sounds like an awful lot of what you're doing is putting these things in perspective.
Yeah, and that's a key point. You have to keep it in perspective, because the chances of having a side effect from the virus is 1 in 1 million, 1 in 5 million. Think of the chance of dying from COVID is much higher. So you have to weigh the good and the bad with each.
It's really
that's one of the things I explain to patients. Your risk of having a minor or even a major side effect from the vaccine is much less than getting sick or God forbid dying from COVID.
You mentioned children. I think all of you have children here. We're down to what, 12 and 14 are not getting 12 and up.
12 and
up
up
are getting,
yeah.
without getting private. Your children, I'm assuming you're going to advocate for people to get it, and children.
Yeah, I mean, I'll be very honest and open. I think I'm the only one with a 12.
Yes.
So my son got it 2 weeks ago. He wants to go to tennis camp and track camp and all these camps over the summer. So I was very open about it. If for no other reason than if it helps someone else make a decision that, hey, this doc is practicing what he preaches, so to speak. So yes, and he's getting his second shot actually this weekend.
My oldest is 9, so she can't get it yet, but when the time comes and the FDA gives it clearance, she'll be getting vaccinated as well.
Yeah, the next age group is 2 to 11, and it's expected possibly by September. And that was actually much earlier. Initially, it was going to be first quarter 2022, but we're now looking at potentially September of this year for the 2 to 11-year-old group to be approved.
Yeah, and my kids will get vaccinated too, because our priority is one, their health and well-being, but then you have to think about what will the vaccine allow kids to go back to school, maybe in person. You already see that society, at least in this area, is opening up a little bit, where you can go out to restaurants or even shows. He likes Broadway shows. Not wear your mask, but so
I don't think I want to make that clear.
But I think part of opening back society and getting back to some normalcy is enough people getting vaccinated.
And there's a question online again on Facebook. Somebody just asked, is there any truth to the, again, this is so important for us to be doing this, and thank you for doing it. Any sense that this could affect child's growth, or like of it, any sense of that? I know.
Like child growth, like
Developmentally,
like,
or even in terms of just growth, I think.
So physically.
Physically as well.
You know, I would say look at it the other way. We don't know the long-term sequelae or result or consequences of COVID. We know that COVID has a predilection, so basically it likes the central nervous system. And in children, their brains are still developing. So we are still very concerned of how this affects children going forward in the long term, even those that are asymptomatic or very mild. So I think people should look at the other way. What could COVID cause? And we've seen people have anxiety, depression, OCD, quote unquote brain fogginess. A lot of these, we call post-acute sequelae of COVID, or long COVID, what the vernacular is, in adults, and that's a very real issue. And so I would look at, like I said, the other way around. And a lot of those people had very mild disease. So people say, well, kids get mild disease, and it's true. More than 99% survival rate. What's the big deal? Well, I will say, well, we don't know what the long-term potentials with this is in children who are still developing. So there is nothing to suggest with a COVID vaccine that that's going to affect their growth. One thing I will say is that this technology is such that the messenger RNA gives, like Dr. Coleman mentioned, it's like a post-it note or instructions. It disappears very quickly out of the body. And there is no virus. So you're just basically programming the body to make this antibody and keep it in your back pocket in case it ever sees the virus. It's really, that's a very simple explanation, but the simplicity is what makes it so elegant. And it's not floating around the body. There's no preservatives. There's no latex. There's no egg. It's very simple what goes into it, but yet so very powerful. And there's nothing that would cause the body to attack itself or make antibodies against itself. We call autoimmunity. So like I said, it's exceedingly safe and very just directed against not even the whole virus, just a little portion. You're making just basically a little antibody against just that part of the virus that the virus uses, that spike that everyone hears about, and that spike is what the virus uses to gain entry into our body. So you're just kind of turning off the key. That's it.
So you mentioned development about the vaccine, but think about the development that the kids have missed by not going to school, the social interactions, the education. Remote learning is pretty hard. So I've learned to have to do fractions and not calculus yet.
He's doing fractions and not shaving, apparently. So
not shaving.
No time.
Think of all the missed opportunities the kids have had as far as interaction in sports and stuff. So I think that's one of the things that, we have our blinders on. We have bias about the vaccine causing developmental delays. What about not going to school and not interacting with other kids causing developmental delays? So that's important.
That's a great point. And again, it's so important. That's why I love talking to my doctors. Like, can you give me a balance of what I should be thinking about?
It's all about balance.
Yeah. It's like we are God. We don't know all things, but we're learning as we go.
That is very true. It's very humbling, this whole experience. It has been. And I admit it to any patient out there that our knowledge evolves in real time. And so we never dismiss any of our patients. We understand their concerns and their questions. And that's why I think we're all very happy to always, engage with them, either one-on-one or even events like this, because we totally understand as parents, especially, that their concerns. I mean, they are valid, but I think if people kind of put everything in perspective, it makes that decision to get their children vaccinated much easier.
I think you're absolutely right. We're getting a lot of good questions. I don't want to keep you too long, but we have a question from Rename Perez, I think. The pandemic, and I'm reading this live, so forgive me if I misread this. The pandemic has provided us with more knowledge than ever regarding ventilation and air filtration systems. This might not be exactly all their complete expertise, but together with their impact on spreading or eliminating the viruses, how important will it be for schools to improving classrooms and shared space air quality? She's also read that many of the air purification systems may be doing more harm than good. What does the science say about these most vital tools to reduce COVID-19 spread? I know that's probably a more technical question, not a medical question.
But it's still good, and I will put it one perspective is that we clearly saw that masks worked very effectively in this season, and if we realize that this was one of the lowest influenza years on record. Yeah. So usually when you have two viruses, they often compete, and so we know that we clearly see that COVID-19 or SARS-CoV-2, the virus that causes COVID-19, won the battle. So we know that masks can be highly effective against certain viruses. Air ventilation and flow is a complicated question because from a scientific point of view, we initially thought that if you just spread people out and have airflow, that would solve a lot of our problems. We're now realizing that in a closed room, and this is getting a little bit technical, people eventually start breathing the same circulated air, so someone 30 feet away could potentially still cause someone 30 feet away to get infected. So it's really not, it's not a function of just how far away you are, but it's actually a function of how long you stay in a particular room. So there's a lot of variables at play. You know, it's like, again, if you talk about a mathematical equation, it's not just 1 + 1 = 2. There's several factors in play. Ventilation is important, but it's not the only factor. You have to look at the density of the kids inside the room, the size of the room, how long they're staying. If you have a dense, lower populated room, and or a more highly densely populated room, but they're only staying for 10 or 15 minutes, that's less of a risk than if you're staying in for 2 hours and have a less densely populated room. So I'm not sure if I'm answering the question appropriately, but I would say it's a kind of a complicated issue. But there was a question about ventilation systems and things you can buy. I think you can buy on Amazon, and I would say that those, you know, whether you're using UV light or UVC light, those haven't all proven to be effective. So I think people should not necessarily go out and rush and buy these UVC machines out there and stick them into their HVAC systems. That's not definitively proven to decrease the amount of virus.
Yeah. How about a question of a friend of mine who got the virus early on, didn't want to get vaccinated because they felt they got tested early last spring.
Sure.
They had the antibodies. What do you say about that? How does that work?
I mean, those antibodies aren't necessarily protective, and we do see people who have had COVID get it more than once.
Okay.
And you know, correct me if I'm wrong. The second time they get it, you know, sometimes can be even worse than the first time they get it.
So what I would say is that if you get 5 people get the virus, they're going to have 5 different types of response. We call it heterogeneous. It's very mixed. If someone has are really sick, they'll have a more robust response. But of course, we don't want people to be really sick. Someone who has a very mild illness may have a very mild response. The vaccine ensures it's a homogeneous response. Everyone gets a dedicated, what we call efficacious, durable response. And so just having a cold natural infection is not a guarantee that 6 or 8 months from now you'll be protected. And you're not necessarily going to be protected against the variants where we see the variants of interest, the variants of concern that are circulating currently are well controlled and well protected by the vaccines we have available.
And just like we talked about getting booster shots in the future, the same principle. Even though you may have had COVID, you're going to need that booster to make sure, or hopefully not to get it again.
And you all are following. I'm sure you guys are locked in with CDC all the time. You're always hearing what they're. I mean, is that?
Yes, that's true. Sure.
Is that sort of the gold standard still in terms of what you're listening to in terms of
guidelines? I mean,
protocols and.
You know, there's several societies. There's the Infectious Disease Society of America, which is what I kind of subscribe to as an infectious disease doctor. CDC, it can get confusing because in the beginning, the CDC and the WHO, which is national or global, didn't always agree. But they've gotten a much better job now of kind of keeping our strategies and our protocols in play. There is the art of medicine and the science, so there is always going to be some variation in how people are treated from institution to institution. But that's the art of medicine. But we do use the CDC, the Infectious Disease Society of America, IDSA, as kind of our, since we're tourists, kind of our Bibles that we use as our, it's from a scientific point of view. But, you know, we can sometimes deviate from them slightly.
But I think if there's ever a question, because I think sometimes with COVID, depending on how it was treated, it may be a longer wait period for the vaccine. Always ask your doctor and just say, I had COVID. This is how I was treated. When can I get my vaccine?
Yeah, it's important. It's a very common question. It's like, how long do I have to wait? And the short answer is it doesn't have to be 3 months. Usually within 6 weeks, you're okay to get the vaccine.
Yeah. And part of the challenge is some people sadly may don't have a doctor. And they they don't have the access to like we do to you now. Yeah. I mean, so checking the CDC website is good generally.
Or healthcare. I mean,
local
healthcare. Most of the towns and municipalities have it. I mean, since we're all at Holy Name, I mean, the Rhoda Center in Teaneck. Yeah. You know, you can go to thehолyname.org and register online, and there's also tons of information there. Okay. And they have nurses and other community healthcare professionals there to answer questions. So there's really no reason. You can go anywhere from a CVS to any local municipality, and I'll tell you that the supply far exceeds the demand currently. So you can even walk in. You don't need an appointment. it's not like it was back in March and April when it was a little bit tricky to get an appointment.
I know personally I'm getting multiple emails. I live in Hoboken. I'm getting multiple emails from town, from the state, pushing this. I've already been vaccinated since mid-April now, so it's been lucky. But it's interesting. But it does sound like, to me, as much as it's been challenging, this has been, we were talking earlier today about how so many friends of ours pivoted so quickly and adapted so quickly a year ago, March, to an incredibly difficult, catastrophic medical emergency in the world. And so many of our first responders, frontline people like yourselves have done such heroic work to keep us informed as best you can. And there is no perfect. And it's been such a learning curve for all of us. And yet, we seem to be, knock wood, coming out the other end of it right now. And we can't thank you enough for spending time with us today. Is there anything else, Mr. G? I'd like to thank you so much for being here. Dr. Triolo, Dr. Cigar, and Dr. Coleman. If you have any questions for us, you can always ask us online, and we have a hotline to Dr. Triolo, and then she has a hotline to her friends. She probably wants us to lose her number, but we can always ask her and get good information. But definitely go see your doctors and listen to your medical professionals. They have your best interest at heart. They have your best health at heart, and we are slowly but surely, knock wood, getting out of this. We're walking around with that mask, and hopefully. Will that continue? Do you think we're going to be good? Or are you expecting maybe a resurgence in the fall? Maybe?
Oh boy, I don't want to be a Debbie Downer, but I would say that let's enjoy the time we have. I mean, could there be regional outbreaks in the fall and the winter? Certainly. I don't think they'll ever go back to a national mask mandate, but could there be certain cities that are disproportionately affected that could institute a mask mandate for a week or 2 weeks? That's certainly possible, especially in the fall and the winter. But things are rapidly returning back to normal. I think we should not rest on our laurels, but at the same time, enjoy it.
Amen. We're in church. I can say amen. Thank you so much for being with us today, everybody. Thank you, Doctor. I wish there were more people very quiet. Thank you at home for all your questions, and keep watching this at home. You can please send us your questions. We'll try to answer when we can.